Well, good evening and a very warm welcome to this webinar this evening on the gender diverse patient. I'm delighted to hear that we have 134 attendees registered for the webinar, and for any of your friends or colleagues who were unable to join us this evening, we are recording the webinar and it will be available through our website in due course. I'm very much looking forward to hearing our expert speakers this evening and to learn from their experiences. I'm joined by Kate Nambiar, Alison Berner and Rhea Folkers. And without further ado, we shall move into the first talk by Rhea Folkers shortly. Just to say, as you can see, that I am Vice President of the Royal College of Surgeons of England, and Rhea Folkers is an employee. So we are representing the college. Our other speakers are invited guests, and therefore their views and comments do not necessarily reflect official policy or guidance of the college, just to be clear about that. So moving on, Rhea Folkers is a digital learning coordinator within our learning department at the college. She's the producer of The Theatre, which I hope you might be familiar with, which is an excellent surgical learning and innovation podcast series, which is available through our website, and founder and chair of the college's LGBTQ+ staff network. Outside her work at the college, Rhea is a writer and stand-up comedian with a wide range of publication and performance credits to her name. So over to you, Rhea, please. Thank you.
Thank you very much, Tim, for the introduction. So, yep, as was said, so my name is Rhea. I work for the college. When I'm not working for the college, I'm a writer and a comedian, and I am very humbled to be here to share my thoughts as kind of a palate cleanser for Kate and Alison, who both do very important work helping trans and gender non-conforming people get the care they need, while I, by contrast, my expertise is telling graphic jokes about the effects of hormone therapy on my body to strangers. So, as promised, I'm here to talk about some of my experiences and impressions of the health service as a transgender layperson. I should disclaim from the start that I have been fortunate enough in my contact with the NHS, apart from my GP and the gender service at 56 Dean Street, has been minimal in the years since I started transitioning. So a lot of what I'm going to say is based on impressions I've received from other trans people, as well as conversations I've had in my capacity as a person who spends a lot of time talking to surgeons. So I think it's fair to say that there are a lot of misconceptions, not just about trans people and gender non-conforming people generally, but also about how to approach and treat us in the clinical environment. Many doctors and health professionals, well-meaning though they often but not always are, simply do not know how to talk about us, which can lead to indignities and disrespect at the lower end of things to poor patient outcomes at the higher end. Now, as an example, from my personal experience, the initial referral letter from my GP to the gender identity clinic when I first asked for it repeatedly referred to me as he and him, which, considering I was being referred to for gender services, it probably would have been a good idea to ask me how I wanted to be referred as. If not as a courtesy, then at least as the logical conclusion that could be drawn from what I was asking for. Indeed, the GP kept calling me young man throughout the whole appointment, which was surreal, especially because I had spent months, if not years, building up the courage to ask for the referral in the first place. Now, that said, I am over 30, and I'm prepared to weigh being misgendered against being thought of as youthful. That's not a completely unfair trade for me. And thank you for humoring me. I haven't had a chance to break out that joke for a while. So, of course, that's quite a mild encounter compared to what a lot of trans people get from their GPs in the same situation. And I've heard horror stories of doctors responding with hostility, making trans people jump through hoops to prove they aren't going to regret it later, or simply having no idea what to do with us. So in a sense, at least my GP was aware the GIC existed and knew where to send the referral letter, and without giving me too much hassle about it, even though he clearly wasn't very knowledgeable about dealing with me personally. This is a very small example of the misunderstandings and indignities that many trans people face in the health service all the time, on top of the shamefully long wait list that many trans people face for gender affirming treatment on the NHS, which is no fault of our speakers this evening, and is a huge contributor to a mental health crisis amongst trans people. We are routinely humiliated and disrespected, sometimes out of bigotry, but more often than not out of ignorance. So the story I've told is about pronouns, which is an important thing to understand, but I think it's also easy to assume that pronouns are the be all and end all when it comes to caring for trans people, as they are so often touted as this sort of totemic thing, those are the only thing that a doctor would ever need to know when treating a trans person. And I have talked to doctors as well who said that that is the only thing that they've been told about trans people, is just make sure you get their pronouns right. If you're not sure, just ask. And that's the only thing that they know. But I can think of a lot of things worse than being misgendered. Pronouns are important, but in many ways they're quite superficial. And because they're so often touted as this totemic sort of thing, they often become a distraction from a lot of other more serious issues. And I think people often fixate on this particular aspect of care to the detriment of other issues. Whether or not someone uses the correct pronouns, many trans people, myself included, for us, the only place more terrifying than the beach, which is, I can assure you, an ordeal and probably a whole other talk on its own, is the hospital. And for good reason, because being taken to the hospital, especially in an unconscious state, is one of my greatest fears in life, because I dread the thought of being laid out on an operating table as an individual with both breasts and a penis, unconscious and defenseless against the threat of indignity and ridicule at the hands of people who may have had few encounters with people like me, or at least people that they were aware of were like me. Additionally, you might have heard of what is known as trans broken arm syndrome, which I'm sure Kate and Allison will discuss much better than me, wherein a trans person is taken to hospital for something mundane in order to stop their hormones as part of a completely unrelated treatment. So if I go to hospital for appendicitis, I now, on top of everything else, have to worry that a doctor might take me off my hormones, which I need. There are much worse things that can happen to a trans person in the hospital than being misgendered, and I think it's important that we not lose sight of this. Now, I often have conversations with surgeons and colleagues where I express these fears and discuss the anxieties that trans people have at the thought of coming into contact with the health service. And something that has constantly baffled me is how often I hear something along the lines of, well, if they're not a urologist, then why would a surgeon ever need to see a trans person? As if the only time that we would need care is in the context of gender-affirming care, as if we were somehow immune from gallstones or impervious to road traffic accidents. There remains a disconnect in many people's minds where trans people are always visible and forever seeking gender-affirming care. And it's surprising how little thought is put into the idea that some people may have received the care that they require, and many or may wish for varying degrees of care, and sometimes not at all. And as such, it becomes difficult for many to conceptualize trans people as being amongst us in society, in settings and appearances where they may not be immediately obvious or visible. But there are 500,000 of us in this country, so the chances of you running into one of us is quite high. But believe me, I would love a little more than to possess the superhuman ability to not have to worry about getting cancer. But for now, I am limited by the same human failings as everyone else. And like everyone else, I will most likely come into contact with a surgeon in a non-professional context one day or another. And I pray that that surgeon knows well enough to treat me with dignity and respect. So with that, I will end my little opening act here and pass things back to Tim to introduce Kate and Allison. Thank you very much for your time, everyone.
Rhea, thank you very much indeed for that. I think it more than explains why we wanted to put on this webinar this evening. So thank you very much indeed. And we'll move on then to a joint presentation now between Alison May Berner, who is a specialty trainee and clinical research fellow in medical oncology at Bart's Cancer Institute, where she's undertaking a PhD in cancer genomics. She's also a part-time specialty doctor in adult gender identity at the Gender Identity Clinic in London. She provides advice and assessment for gender diverse patients with cancer or genetic cancer predisposition, and leads a number of research projects related to improving cancer care for LGBTQ+ populations. She's assisted charities including Cancer Research UK with their patient information for the trans community, and she is also a trustee of Live Through This charity for LGBTQ+ people living with and beyond cancer. And Kate Nambiar is a specialty doctor working in the Brighton Sexual Health and Contraception Service and the London Gender Identity Clinic. Kate has worked in sexual health since 2003 and is chair of the British Association of Sexual Health and HIV Gender and Sexual Minorities Special Interest Group. She has co-authored national recommendations for the care of trans people in sexual health clinics and guidance for contraception provision for trans people. In 2012, she helped to set up and continues to run Clinic T, a specialist sexual health service in Brighton for trans and gender diverse people. So Alison and Kate, over to you, please. Thank you.
Thank you so much, Tim, for that very kind introduction. I am very honoured. I think both of us are very honoured to be here to speak to you all about this topic, very dear to our hearts. I wanted just to start by saying that we've pitched this topic very much in the light of what Rhea spoke about. And not talking about the sort of detailed medical care of trans people in terms of gender affirming treatment, but more about how you look after us, and I include myself as a trans person as well, in that as patients that you might see in your everyday service and through your clinics, or as colleagues working within your institutions as well. There'll be plenty of time at the end to ask about more questions, so we can go into things in a little more detail at that point. But I just wanted to start by prefacing how we're going to kick things off. So
and we'll also have a kind of discussion section with myself, Kate and Rhea, which actually Rhea's opening monologue has been an excellent primer for. So thank you so much for sharing in your experience with us, Rhea. So really, one of the things that is often said to myself and Kate when we give teaching to people on equality and diversity, in particular gender diverse patients and their care, they say, well, can't we all, if we're all equal, can't we just treat everybody the same? And I'll point you towards this infographic, which is frequently used to describe the difference between equality, equity, and justice. And even though we are all entirely equal, we may require different things to mean that what the care that we receive is equitable. We might have different particular needs, have different past experiences, we each have different identities, we have different body parts. And so really to provide that equitable care, we need individualized, tailored thought. And that's both in the medical aspects and also in things like the communication aspects. And true justice comes to our care where not only do we provide things to overcome the barriers, but actually we take the barriers away entirely. And I think it's important just to cover a little bit about the background of sexual orientation and gender identity, just so that the kind of playing field is level with prior knowledge. This is something called the SAGE model. It was developed by Live Through This, the charity of which I'm a trustee, and it describes some of these key aspects of identity which are different. So you have the sex that you were assigned at birth, usually based on a nurse or doctor looking at the genitals of a baby when they're born. But that might be very different to your gender identity, which is your inbuilt sense of your gender, and you may choose to express that in different ways, depending on the clothes that you wear and the behaviours that you choose to employ. And that again is quite different from your sense of attraction to one or more genders, which is your sexual orientation. And in this particular webinar, we are simply dealing with the gender diverse community, so those whose sex assigned at birth and their gender identity are not the same. But it's important to remember that these aspects of identity may integrate with many others, and that kind of intersectionality is very important, again, in providing that individualized patient care. Hand over to Kate to do some other definitions.
So yeah, I just want to talk a little bit about some terminology, and although this may be all very basic stuff, and some of you may know this already, I think it serves us well to start from the basics and to just describe this, because there is a lot of terminology out there. Some of it's quite old-fashioned, some of it is perhaps not so appropriate nowadays, and some of it is still present in some of the old literature that you might come across. So when we talk about somebody as being trans or transgender, it's an adjective. It describes a person. It describes a situation where there's a mismatch between your gender identity, and that's your internal sense of what your gender is, and that sex that you were assigned at birth, and that's what appears on your birth certificate initially. Now, when it comes to gender identity, most of us don't really have to think very hard about gender identity. It's just you just assume that's what, you know your gender. You just assume it. But when there is that mismatch, and one feels that sense of incongruence between our identities and the bodies that we have, we can describe that person as being trans or transgender. And if you just move to the next slide, and because it's an adjective, we can describe a person. So we describe, like this guy, a trans man or a trans masculine person, somebody with a male gender identity who was assigned female at birth. And the next slide. And a trans woman is, or a trans feminine person, somebody with a female gender identity who was assigned male at birth. And I would say, actually, don't be fooled. Most of us don't look like supermodels like these are, but we're very much more ordinary than that. The other thing that we should think about to describe the majority of the population, and where people's gender identity and sex assigned at birth matches, again, we can describe somebody as being cis or cisgender. And I think that there's been some controversy about the use of those terms, trans and cis, but actually they come from Latin terms, trans meaning the opposite side, cis meaning on the same side. They're used very widely within science. If you think about your cell biology, you think about the Golgi apparatus that has a cis side and a trans side. Think about organic chemistry, we talk about orientation around a carbon double bond as being trans orientation or cis orientation. And so these are scientific terms. They're not. There's nothing unusual or sort of woke or PC about them. It's just a way of describing people and trying to move away from just talking about a group of people as being a normal group and then an abnormal group. When we talk about gender, it's important to think that gender is a spectrum. And I don't mean that there's this sort of sliding scale between femininity on one side and masculinity on the other. It's a spectrum in the same way that color is a spectrum. You don't say red is a bit more, it's a bit less blue than whatever green or something like that. They're different, although they're interrelated. And when you talk about somebody as being non-binary, we can describe their gender identity as being neither exclusively male nor exclusively female. And there's a large proportion of people who are non-binary. Just move to the next slide. It's probably about a third of people who have a trans or gender variant identity will say that they're non-binary. And there's a lot of other language that goes alongside of that. And in fact, that the whole concept of gender variance or gender diversity is something which isn't unique to us within Western societies. It's actually been part of human experience for thousands and thousands of years, and cultures all throughout the world have different language to express the people who have variances in their gender. So I think we need to have a think about this in terms of the scale of, or the degree of inequalities that trans people face. And Ria touched on this initially, and Alison mentioned it right at the time of the first slide, because there are a significant number of people who avoid healthcare treatment because of fear of discrimination, and people who have negative experiences related to being trans. A little over a third of people who are trans will say that. We can see that 7% of trans people have refused healthcare as a result of being LGBT, and when accessing general healthcare in the last year, so 2 in 5 trans people, healthcare staff lacked understanding of trans healthcare needs, and that's a really worrying situation to be in. And this comes from data obtained through a survey done by Stonewall. And in fact, that information, that realization that trans healthcare really isn't really up to scratch, is something which hasn't gone unnoticed by our politicians. And in fact, the House of Commons Women's Equalities Commission, in a report at the end of 2015, stated that the NHS is letting down trans people and it's failing in its legal duty under the Equality Act. Trans people encounter significant problems in using general NHS services due to the attitude of some clinicians and other staff, knowledge and understanding, and in some cases are prejudiced. And as a doctor working in the health service, that really does break my heart to hear that. And I think that is sort of incumbent on us to really do better. Maria mentioned this issue about the so-called trans broken arm, because being trans is often not really relevant to many of the aspects of healthcare, and sometimes there is this tendency to think about somebody's trans identity as being perhaps in some way related, whereas it may be, but often it isn't. So if somebody breaks their arm, it's more than likely it's because they had a fall, it's a traumatic incident, rather than as a result of inadequate hormone therapy and being hypogonadal, they've become osteoporotic. So it's sort of an Occam's razor type of situation. It's important to bear that in mind, but if the automatic thought is that, oh, it's because that person is trans, but then I think that we go into a situation already being biased in terms of how we approach that patient, and I think that's not a good situation to be in. So let me hand back to Alison to talk a little bit more detail about that.
And having said that, and I apologise, there was an error on the last slide. I don't know what had gone wrong with the display of it. Having said that, the majority of the problems that a person might present with will be entirely unrelated to any gender affirming care that might be accessing, or the fact that they're trans. There are particular changes to anatomy or physiology that come with some of the medical aspects of transition that are really important to bear in mind, not because they're going to be responsible for every healthcare problem that a trans person presents with, but because if you don't know them, then you might miss something relatively important. And I'll caveat this with underlining the fact that not all gender diverse people choose to access medical gender affirming care or a medical transition. They may opt for a social transition alone, and if they do opt for gender affirming care, it might not necessarily be through NHS treatment, and it might differ slightly from what I'm about to say. So a trans man, as we've covered, someone assigned female at birth that identifies as male, or a non-binary person who was assigned female at birth, might choose to access a range of gender affirming interventions. So testosterone, which is a very powerful hormone and will change many aspects of external appearance, such that you may and are quite likely to have no idea that person was assigned female at birth. There's often a lot of voice deepening, facial hair, and so on and so forth. They might also access a GnRH analog, which you might be familiar with as a prostate cancer treatment, for example, or used in some breast cancers, which switches the gonadal function off. And so patients may be on that as an injection. The testosterone might be also an injection or a regular gel the patient is taking. And so if somebody's on the ward, and they may need to be prescribed that testosterone every day to apply in order to keep their hormone supply going. Some people assigned female at birth will also be on a progestogen, which you may say, well, why is someone going to be on that? Because it's a quote unquote female hormone, but it can be used to stop menstruation, for example. A large number of transmasculine people or non-binary people assigned female at birth will choose to have a bilateral mastectomy and male chest reconstruction, and have a flat appearing chest and a masculine appearing chest. It's important to know that some breast tissue is left behind, and so therefore susceptible to breast cancer, and the risk for that cancer in transmasculine people or non-binary people who are on testosterone and have had male chest reconstruction will fall somewhere between that for cisgender males and cisgender females, and in rare cases all of that tissue is removed, and that's an important thing to bear in mind for people that have a genetic predisposition to cancer, where they might choose to have all of that tissue removed. The numbers of people who are transmasculine or non-binary but assigned female at birth and having hysterectomy is actually declining, and so these patients might require gynecological care, and a bit of a thought as to how that's delivered, given that they're unlikely to want to sit in a quote unquote female clinic. And genital reconstruction is only undertaken by 1/3 of trans men, or perhaps less in the UK. So this is surgery to make a phallus, a phalloplasty, or metoidioplasty, which is a slightly different surgery, and takes advantage of clitoral growth on testosterone in order to provide a neophallus. Of note that surgery, particularly phalloplasty, is multi-stage and quite complicated, and people might get complications after it, and it's no wonder that a great many of people choose not to opt for it. And in the case of trans women, so those assigned male at birth but identify as female, or non-binary people who are assigned male at birth, they're likely to be on estrogen, which might be in the form of tablets, patches, or gels. Again, important to bear in mind if someone is prescribing that on the ward. Much more likely to be on that GnRH analog, or perhaps on the drug finasteride. Previously, a large number of people were on soproterone, and use of that is fading out now because it was linked to meningiomas, but you may still see people on it. Breast augmentation is taken up less because it's not currently offered to trans women on the NHS, but you may see people that have had it privately. And that's because estrogen, dosed correctly, causes breast growth around a cup size less than your mum or sister. And then also genital surgery, which here you can see pictured vaginoplasty, which creates the potential space of a vagina and actually shifts the prostate forward, which is important to know if someone's coming in with urinary symptoms or symptoms that might suggest prostate inflammation or malignancy. But patients might also opt for a cosmetic vulvoplasty where there's no potential space of a vagina, so don't go looking for one. Ask the patient what surgery they might have had if it's relevant to be performing that sort of exam, and that surgery is done often for patient preference and is slightly less invasive. And you can imagine thinking about some of those aspects of medical gender affirming care where healthcare needs therefore for a trans person might differ. So you might imagine that in public health, the screening needs might be different. So if breast cancer risk changes, you would need to ensure that trans men are having cervical screening if they have a cervix. Cancer risks might differ. Trans men may wish to become pregnant, and so that requires a bit of extra thought. And if you're doing something where being pregnant is a risk, you need to ensure that your patient might not be pregnant. And even thinking about something as simple as considering an acute abdomen in someone. If someone is assigned female at birth but identifies as male, they may well have organs that mean that ovarian torsion might be relevant, but you might not consider it initially by just looking at them, because the person in front of you assume to be a cis man, but they're not. And so it's important to kind of ask the right questions, take the right cues, and ensure that you're keeping the right differentials in mind. Something of particular note really is mental health, particularly because of some of those inequalities in care, ongoing discrimination and dysphoria, which people might experience due to either the way that they're gendered or the body parts that they continue to have that can make them very uncomfortable. There's many different forms of dysphoria. And I'll just let Kate talk a little bit further about mental health.
I think it's a really big topic and we're sort of going to skirt over quite a bit of it. But I think one of the things that is important to bear in mind is that there have been some changes in how gender dysphoria or gender incongruence is classified. So in the past, it used to be classified as a mental health disorder. It no longer is. The WHO, in the most recent International Classification of Diseases, ICD-11, has moved that out of the disorders associated with mental health. It's actually now put into conditions associated with sexual health, and there is some debate as to whether that's the right place for that. But I think it is important that for people who need, particularly in other parts of the world where you actually need to access a diagnosis in order to access healthcare, that it is still there. But I think what we're trying to do is very much move towards depathologizing trans identities and moving away from depathologizing gender dysphoria or gender incongruence. When we look at studies of mental ill health, what we see is that there's an increased prevalence of conditions like depression, anxiety, and sadly increased rates of illicit drug use and of attempted and completed suicide as well. And much of that is attributable to the minority stress that we experience as trans people trying to live within a majority cisgender world and in a majority world where people think about gender as being immutable and very much binary, and it's not easy to try to fit into that situation. And something like just going to the toilet can be an immensely stressful experience. I remember once actually going along to a sexual health clinic, and it was an old-fashioned clinic, and it had a male waiting room and a female waiting room, and sort of taking a deep breath in and just walking into the women's waiting room to sit down. And of course, nobody else minded at all, nobody else was bothered. But for me, the stress levels just shot through the roof, and I can imagine a lot of people would look at that in that sort of situation, just turn around and walk out of the door. And I think that on a cumulative basis over and over again contributes to much of the mental ill health that people do see. What's interesting is that other mental illness, schizophrenia, bipolar affective disorder, all of these other conditions, there isn't an increased prevalence amongst trans people. And often what we see is that people who have been through a process of transition, studies have shown that the prevalence of things like anxiety and depression drops significantly once people are able to live authentically in their real gender. So yeah, let's move on from that. I'll hand back to you for this one. I don't talk about this.
I think sometimes we often hear from people, well, the world's moving forward, there's not so much discrimination anymore, why people can just relax and come here and receive whichever equal care. But we very much still live under a burden of the time when things were not so forward thinking, and when there was much more discrimination, anxiety, when homosexuality was illegal, for example, and a great number of patients that you will see presenting with healthcare conditions in later age now will have lived through those times, and will still be experiencing the effects of previous discrimination, which might prevent them engaging in healthcare now. And you can see here just some of the quotes from this really great piece of work from the Palliative Care Council, which just kind of describe the sorts of things that will be in people's minds when they're then coming and being openly out in the clinic. And I've actually seen patients at the gender identity clinic who took a long time to come out as being trans, because if they were trans, then that meant that actually that their sexual orientation would be gay or lesbian, and actually for them the actual thought of being classed as being homosexual was even more stigmatizing than being trans. And so it's just, I think it's just something to have in the back of your mind when you're kind of asking questions and getting to know people and wondering why people are finding it quite difficult to engage. So we've got some tips on how to consult well, and a little video before we move on to our discussion section. So I'll let Kate kick off.
Okay, so I think there's this is quite basic stuff, and I hope you'll forgive us for approaching it like this. I suppose many of you are very, very experienced and have done many consultations with patients. I think it's just as Ria said right at the start, sometimes it's the basics that we need to just take a step back and have a look at again, particularly when you're dealing with a patient group that you're unfamiliar with. And I think a lot of times as doctors, we're very used to sort of feeling like we're in control, we know the situation, and when we're put into an environment or have a consultation where things are where we don't know everything, and it can feel very it can feel a little bit disorientating, and it can sometimes, and that can come across to your patient. And I've been in consultations where it's been like that. I remember speaking to a GP, well, not my usual GP once, and then she was a little bit unsure of why I was on this hormone replacement therapy, as I was very young at that time. And so when I told her that I was trans, I could see her sort of suddenly get really, really flustered about it. And it's those sort of perceptions that patients pick up on that make our consultations much harder. It's important not to assume things, and to ask if you're not sure. And I think I'd much rather that as a patient, that if you ask, rather than making assumptions and getting it wrong. That's never a good situation to be in, I think, generally in medicine. Ria mentioned this, and names and pronouns are important. They're certainly not the be all and end all, but doing the basics, like getting somebody's name right. If somebody says, I really want to be called this, calling the person by that name is not a hard thing to do. Using the pronouns that are appropriate for that person is, again, it's not a hard thing to do. And there's a little video after that about pronouns. So, and we're all human. We make mistakes. If you make a mistake, just apologise and move on. Don't make it into a big deal. I think the overwhelming majority of people who work in healthcare are not out to be horrible to trans people. I genuinely believe that. And we sometimes make mistakes because, as I say, we're human. We didn't realise something. We said something inadvertently. If you make it into a big deal, then it just highlights that. It just makes us as trans people feel even more alienated, because now I feel bad because I've made you feel bad because you're apologising to me continuously. So just say sorry and move on from there. Should we just play this? This is a little bit just talking about the importance of pronouns. Are you able to hear the sound?
Can you not hear it?
You can't hear it.
It played
no.
when we did. I'm not sure what happened there, because it played perfectly when we did the rehearsal. But we can direct you towards this. As you say, names and pronouns in 60 seconds by this organisation called misgendering. In the interest of time, I won't try to fix it, but I'll point you towards that.
Okay. Yes. So the next thing I think is when it comes to consulting well, is to think about why you're asking somebody about their transition history. And it may well be relevant, it may well be important, and we'll talk a little bit about some other issues later when we have a little bit of a chat. But make sure it's in context and you're able to justify the questions that you're asking. One of the things that people often will say as a criticism is that this doctor asked a lot of very intrusive questions, and it was hard for me to see how they were relevant. I think if you can justify it to your patient, then and you can justify the reason for asking that, then it's often good to actually say that. It's important to think about medications that are prescribed and medications that aren't prescribed. There's a significant proportion of trans people who are self-medicating, and that's an unfortunate situation. It's something that is unfortunately a reality of the fact that there's an enormous waiting list to be seen in for gender-affirming care, and that people often feel that they can't access the care that they need in a timely fashion, and so resort to treating themselves. And obviously it's important to think more widely about the social environment and the situation that somebody's in. Thinking about examinations, offering people a chaperone, giving people a choice of who they're able to see, I think it's a really, really helpful thing to be in, or thing to do. And as Alison mentioned, that there are a number of anatomical and physiological changes that occur as a result of gender-affirming care, and it's important to bear some of those in mind, and to tailor your consultations appropriately. When we're talking about requesting investigations and sampling, it's also important to think about the confidentiality of that person when you're disclosing that. And there certainly have been some high-profile cases where confidentiality has been breached because somebody put down that somebody's transgender, and that blood test form ended up with a phlebotomist who saw that, and that patient wasn't aware that that was the case. It's always helpful to talk to a patient and say, you know, I need to inform the laboratory or the ultrasonographer or the radiographer that you're trans because, and then justify that, because I think that's common courtesy, and it's just it also crystallizes in your mind, you know, why are you asking for this investigation, and what do you need to know, and why does that person need to know that that person is trans. And I've been in situations myself where somebody hasn't done that. They didn't ask me. They didn't mention that I was trans. I had an MRI of my pelvis, and it took ages for it to be reported. And I found out, this is in the trust that I worked at, they'd been passed from radiologist to radiologist, but nobody could figure out what was going on because the anatomy looked it looked very, very unusual. And I actually ended up phoning up one of the radiologists who had it on their list to report and say, can I give you some more clinical information, because that would be important for you to be able to interpret this. Now, most people won't be able to do that. It just happened to be because that was the trust that I was working in, and I knew that person who had that on their list. But I think that you need to take a balance between delivering the correct amount of clinical information and respecting the privacy and rights of the person who you're seeing for their confidentiality. Similarly, when you're interpreting test results, it's important to think about how you look at it. Some things do change. We talked about physiological changes. So something simple as the hemoglobin result would change in response to hormone therapy. So someone who's assigned female at birth will have a higher hemoglobin as a result of EPO production because of testosterone therapy, and so their normal range will move towards male normal range as that person starts on gender-affirming hormone therapy. And there's several examples of changes in reference ranges as a result of that. But when you think about it, those reference ranges, there's an enormous overlap with that. These are fairly subtle changes that do happen. But it's important to think about those in mind. And also to think about, you know, when you're admitting somebody to the hospital, just like Ria said, you're in a very vulnerable place as a patient, and to be thinking about where you're putting that person and treating that person on, you know, in the ward, I think is a really important thing to consider. Okay.
So just a few quick fire tips before we then share a little bit more of our experiences. So as Kate has said, get the basics right and don't be afraid to ask the patient their preferences. Treat patients as individuals, as people, and don't make assumptions. Get training beyond this webinar and don't expect the patient to be an educator. Be a good ally and advocate for patients and staff who might be trans and gender non-conforming, especially when they're not there to perhaps correct people's pronouns, and involve gender diverse patients and staff in improvement and research where you are. You may not realize your cisgender privilege, and as a cisgender person myself, I frequently am alerted to things that I would not have considered when I'm part of these groups and planning improvement and research. So we wanted to take a moment to just share some experiences, and we've had some questions sent in advance, and I know this will probably end up feeding directly into the Q&A due to time pressures. But we thought it good to kind of share some of the experience we've had as both healthcare professionals and patients. I wondered if I might kick off by asking you, Kate, what your experience has been as a patient, if you're happy to share some of that with us, and as a trans person, you've shared some insights already.
Yeah, definitely, and I think that it should be said that the majority of experiences that I've had as a patient have been very good ones. I've been very fortunate in that respect. So, you know, I went through my transition, you know, just a bit over 20 years ago, and I had a type of surgery called colovaginoplasty, which is an unusual type of surgery. The majority of trans women don't have that particular surgery, and we'll go into the reasons for that. But it did involve using part of the bowel to form my vagina. And unfortunately, I ended up with some complications as a result of that, and had a very prolonged period of bowel obstruction. After the surgery, required another laparotomy, and I was in hospital for a very long time. And I've had a number of adhesions within my abdomen, and have had several admissions in the intervening years under various different surgical teams, sometimes in the trust that I work in. So I have some experiences, and as I said, the majority of times people are very respectful and people have been very understanding, and a lot of times it's simply a case of me telling the person the history, people understanding, okay, that may be relevant, and that's it. But occasionally things don't always go according to plan. The last time I was admitted was last summer, and I recall needing to have a catheter put in, and fairly straightforward procedure, but nobody could figure out, or nobody could make a decision about who should do it. Nobody asked me about it, but it seemed to be, one person realised that I was trans, so I can't do that, and passed it on to somebody else. Eventually, it was passed on to a consultant urologist, and the whole day had gone by this stage. And he turned up with his entire team and a whole load of medical students, because they'd never seen a trans person before, and asked at that point, would it be all right if they all watched while this catheter was being inserted? And I think as a patient, when you're in a very vulnerable position like that, it's very hard to say, oh no, I'd rather not. But it did make me feel very, it made me feel like a lot of my dignity had been stripped away. And I think that it's hard as a patient in that situation. I think it's harder as when you know as a doctor that it's also important for people to learn and to know what the situation is, and to understand about trans people, which is why we do these talks. But I think there's a balance to be gained, and it's important that for all of us, we respect the patients that are there in front of us.
Thank you very much for sharing that, Kate. I've heard that story before, but it doesn't matter how many times you tell it, I feel it to a certain extent. I feel for you, because how much do you want someone to advocate when someone's in that very vulnerable position? And I think that for all the audience, just to have that bit of thought to advocate for patients, because there may be other staff around you who are just not thinking, and who are putting patients in an all the more vulnerable position.
On that note, can I ask you then, what ways do you think we can better tailor patient care, more general patient care rather than specific gender affirming care, that really accommodates the needs of trans and gender diverse people?
I think we need to just have a very kind of individualized thought for each person, and really try to put ourselves in other people's shoes in the same way we would for any characteristic. So and if you think from that point of trying to imagine yourself a little bit in that person's shoes, then you get some insights into what they might be going through, and then you can also ask them, and it will prompt you to ask them the right questions and be driven by what they might need. So thinking about asking patients in what clinic they might like to be treated, if it's a gender related condition, for example, and providing gender neutral options for where people can be treated. I think that's a really key and kind of important thing. We need to develop much more patient information that's neutral, and then that's also tailored to people who are gender non-conforming. And I think that's particularly important because there was a piece of research that showed that in a large number of cases patients are expected to be the educator, and whilst it's important to ask patients what they need. We shouldn't be asking them to educate us about them as a trans person, because everybody is different. But because they're being asked to be the educator, they're relying on information that's out there, that's tailored towards them, and that has to be accurate and of the highest quality, where there are specific needs for people who are gender non-conforming. We also got some other questions from in advance of the webinar, and I'm sure we can kind of slip seamlessly into the Q&A by maybe kicking off with some of those. Kate, what do you think? And also Rhea, I think you've seen some of those, and so I guess I'll ask them to both of you. What one of these was, some excellent questions. So we kick off with many trans individuals feel the need to self-medicate with hormones due to waiting times to access this treatment through the proper routes. What can be done to increase harm reduction measures amongst medical professionals, and how can we make it clear to patients that they're not being judged, reprimanded, or forced to stop this treatment?
I think that's something that we see a significant proportion of people doing now, and I think that it perhaps is not surprising when you realise that the waiting times to be seen in a gender identity clinic in now many years from the time of referral, and that's simply because there's inadequate care provision given the amount of people who are seeking treatment, and that's an alarming situation for us to be in. It's been that way for many years, and although the NHS is trying to make some new initiatives in expanding services, it's still pretty inadequate. So one of the things I think that is important to bear in mind is the balance between people as patients desperate to access treatment, which for many of them can be transformative, life-saving in some respects, versus the importance of being able to keep somebody safe. If you're treating yourself without any medical supervision using hormone therapy, then although for the vast majority of cases it's safe, it's well-tolerated treatment, there can potentially be some complications and problems that can arise, and sometimes those may not be picked up until very late, and that's not a good situation to be in. It's not something that I as a doctor can really advocate. But I completely understand the position of patients who are desperate for care, who do seek that, and many of the people who come and see me within my clinic in Brighton are in that situation, and I in that situation do my best to intervene and try to provide people with the appropriate monitoring that they will need, and often will write to the GP and say, well, I've seen this person, would you consider prescribing their hormone therapy through the NHS up until the point that they are seen within a gender identity clinic, and also a more formal assessment, which can then take into account further treatment can be instigated. And I think that within all of this, we're having to realise that the NHS is not perfect. We need to do better in terms of the care that we provide to trans people. That's a given. That should be that's quite obvious when you look at the waiting times and the gap between the people needing treatment and the people who are able to access it. But we do need to be able to do something in the meantime. We can't just say, oh, people should just wait. No, that's clearly not. That's clearly not going to work. We need to find some way of being able to look after people in that situation. It's not easy. What would you say to that?
Yeah, I mean, I would say, fairly similarly. It's making sure that whatever decision someone is making regarding their care, whether it be self-medicating or otherwise, it's moving. And I think this alludes to maybe another question that we did receive in advance around moving towards informed consent for gender affirming care, and that if people are aware of what the risks and benefits might be, then we're not in a position to weigh those up. It's the individual person that's weighing those up, and someone might choose to accept an increased risk of a particular cancer or another health condition, you know, in order to access a hormone, because that's what's going to give them the overall benefit and well-being, and that's not that you know, when someone with, you know, with capacity, that's not our decision to make. It's their decision. It's our job to give people the facts so they can make the best choice for them. Rhea, did you have anything to add?
Yeah, just very quickly, yeah, because I think just kind of as a follow-up to kind of the story I was telling earlier about me going to the GP to ask to be referred to the gender identity clinic. I mean, you know, it had been quite a long process of trying to work up the nerve to get to that point where I could book the appointment to the GP and ask in the first place. And then once I did that, I was faced with the prospect of, you know, well, now I've done this and now I have to wait for years. So I ended up going privately for my diagnosis of gender dysphoria, which allowed me to enter into a shared care agreement with my GP until I was picked up by a trial program from 56 Dean Street. But I can really, you know, I can sympathize with people that, you know, kind of enter into these sort of situations where self-medicating and stuff like that, because I'm in a very privileged position, having a full-time job with the college here, and you know, and I could afford to do it at the time, but for many people can't, and it is a very desperate thing, and it's a very it's a long stretch of time to look down after you've kind of gone to your GP and said, I'm trans, what can I do about it? And then the only answer that you have is, well, you have to wait 3 years at least before anyone will see you. So the idea that, you know, anyone would be reprimanded for self-medicating is a bit beyond the pale, because even though, you know, obviously resources are very stretched, and as Kate mentioned, the NHS is doing things to open up care a little bit more, like at Dean Street and whatnot. But at the same time, I mean, there is, you know, we hear in the trans community all the time about people dying of suicide because of intolerably long wait times. So
Jane, do we have any questions coming from the audience that we can put to our panel?
We do. Some of them are quite long and complicated. I've got a couple which, if it's okay with everyone here, I may take offline with recommendations for speakers and things like that. So I'm going to focus on the questions relating to tonight's talk, which has been fascinating. Thank you all so much. So there's a few on sort of similar themes. Lots and lots of praise and thank yous as well, so I will forward those separately. But do you know of any plans for anything like nationally approved guidance for primary care doctors to help people find safe sources of hormones while they're waiting to be referred, and sort of basically questions about how to protect patients from harm, I guess is the thought. So what do you do with somebody who's facing that waiting list? Is there guidance available, or is there plans for guidance?
Do you want to make a start on that one, Kate?
Yeah, there is some guidance that the Royal College of GPs has provided, but it's not been without some controversy. And I think that some GPs feel that it's not their place to be doing assessments on people for because of their gender dysphoria. I would say that I would counter that and actually say that that is an important part of the role of GPs, but you know, I think that's maybe a somewhat slightly different debate. I think that it's very difficult to be in a situation where we can recommend sources of hormone therapy outside of standard prescribed routes. I know that has happened within my field in sexual health when we were in a situation with PrEP, so pre-exposure prophylaxis for HIV prevention, and that was only being provided in the NHS through a clinical trial for some years, and as a result of that, various initiatives were set up to work with various different pharmacy sources to be able to say, well, you know, you can buy your PrEP through this service, and us as sexual health doctors, we will look after all of the sort of the monitoring, the sexual health screening, all of that sort of stuff. The only bit you have to do is to buy it through there. And we, as a result of that, there's some really tight networks that formed between the providers, the pharmacies, and third sector organisations. And one of my colleagues, one of my colleagues said to me, "So, why don't we do that for trans healthcare? Why isn't there a situation where you have iwantprepnow.co.uk? Why is there not an iwanthormonesnow.co.uk service?" And I think that I have some sympathy for that. I think that ultimately, I think the situation should be that we do have better education, better guidance for our primary care practitioners, that people feel confident in looking after the trans people who are within, who are coming to their service, and in a situation where they're waiting for specialist help, and for people who are otherwise straightforward, that people feel confident to be able to prescribe initiate hormone therapy without needing a detailed process of psychiatric evaluation and such like. I think that the field of trans healthcare is moving past that, and like Alison was saying, that we're really trying to advocate and move towards putting the patient more in control of this, and giving people more autonomy, but making sure that somebody is safe and that they are appropriately looked after. So it's not a case of it's a sort of free for all, but there is medical supervision that goes along with that. So.
Thank you, Kate. Jane, I'm conscious of time, but perhaps we could have one more question before we wrap up, if you have one for us. You're on mute.
This is like webinar 50 something for me, so my apologies for that. So we've got loads and loads of really positive comments coming through, which I will share with the panel afterwards. Lots and lots of praise, lots of calls for this to be more compulsory training, and those sorts of comments. But I think the ones that I am going to finish on, sorry, trying to find it again, it's on a sort of similar theme to topics we've covered, but how do you, sorry, Rhea, but I feel this is probably one for Alison and Kate, feel about how the undergraduate curriculum manages the teaching of dealing with gender diverse patients? And again, I guess sort of like any thoughts on how that could be improved? So I'm trying to summarise very badly. My apologies to the people who wrote very eloquent questions.
That's okay.
Perhaps go to Alison on this one.
Yeah.
Well, Kate and I have delivered a number of similar webinars to this to various medical schools, and there's a varying degree to which LGBTQ health is integrated into the undergraduate curriculum, and there's some really excellent leaders in this. Places like Manchester UCL, who have their own programs which run vertically through the undergraduate curriculum. So not just tackling particular areas of healthcare need, but ensuring that LGBTQ people are represented in all the different specialties as just, another person, another patient that you're going to treat day to day. And that's really the way to do this. And in combination with specialist modules, there is a move to make this a much more compulsory and standardized area. The charity LGBT Foundation have actually formed a working group, which I'm part of, to see how we can bring the medical schools together and to move this forward, so that it doesn't matter what medical school you go to, you have equitable teaching on gender diverse healthcare. So what I would say is watch this space. We know it needs improvement and standardization. There's some great offerings out there already, and I can only see it improving.
Great, Alison, thank you very much. We've run a few minutes over, so I do apologise for that. But it's been a really fascinating webinar this evening. I've certainly learned a great deal, and I'd like to thank our three speakers for their insight into gender diverse issues, and for being so frank and open about their own experiences, which I think has been really insightful. So thank you very much indeed for that. You can see on the screen information about our confidential support and advice service, which we're very keen is available to our members and fellows for any range of issues that they may wish to contact the service about. There are lots of resources available within hospitals and elsewhere, but this service is available as a benefit to our members if there are any issues that you feel it would be helpful to talk to one of the trained counsellors about. So you have the number there. It's available 24 hours a day if you need to make use of it. So thank you. So I'd like to thank everybody for joining us this evening. As I said at the beginning, there will be the opportunity to review this webinar, and any of your friends and colleagues who may have missed it will be able to see that on the website in due course, together with information about previous webinars that you might have missed and our webinar program in the future. You can see on the screen there our various social media outlets, which I hope you may be familiar with, but please do make use of those, and we look forward to seeing you again in due course. Thank you very much and good night.
Thank you.
Thank you very much.
Thank
Thanks
you.
a lot.